Hello, sir.
Yeah.
Ah,
Hello.
we can start,
Rajesh, we
Rajesh.
can start, Rajesh.
Hello.
Yeah. Audible. Rajesh, you are muted, I think.
Okay.
Rajesh muted.
In that case, I'll
Then,
start.
yeah, you
Hello,
can.
sir.
Okay.
Yeah,
Ah,
Rajesh. Rajesh, you can start.
okay. Good evening.
Hmm.
Today we are having a neurology case discussion, and we are having Dr. Leema Pauline as the faculty today. Madam is the professor of pediatric neurology, Institute of Child Health, Madras Medical College, Chennai, and she's having 25 years of experience in pediatric neurology, and she has contributed chapters and review articles in books and journals. And she's a very well-known teacher. And actually, we had a PG training program in Calicut 2 weeks back, and we really wanted Madam to be one of the faculty there, but Madam had some difficulty in traveling at that time. So anyway, today Madam is with us, and we are really happy that Madam is here. And today the discussion, the case is being presented by Dr. Kirtana, who is the third year junior resident of Government Medical College, Kozhikode. And I would like to invite Dr. Nandakumar MK, who is the president of IAP Kerala, to have few words.
Good evening, all. Respected Dr. Rajesh, President IAP Kozhikode, Dr. Mohandas, Chairperson, PG Teaching Program, and today's chief guest and teacher, Dr. Leema Pauline from ICH, Dr. Gopi, Dr. Binukutan, Dr. Purushottam sir, other seniors on this platform, and my dear students. Today, we are all very lucky to have Dr. Leema Madam from ICH, my alma mater, because I trained in ICH under Dr. P. Kumaresan sir, Tilottama Madam, and Dr. Chandramohan. And I used to listen Madam's online programs frequently. So all these are going to be very useful for our PGs. I think this is going to be a very good session for our PGs, and wish you all the best for this program. And thank you all.
I think we can start the program. Okay. Madam, can we start?
Yeah, please, sir. Thank you, sir, for the nice introduction by both of you, sir. We can have the presentation by our postgraduate.
So can I share the screen?
Yeah.
You
Yes,
can.
yes.
You can. You can.
Good evening to all. Presenting the case of 10-month-old girl child hailing from Malappuram, informant is mother and history is found to be reliable. Presenting complaint, multiple episodes of vacant staring of 2 weeks duration. 10-month-old girl with history of developmental delay. Sorry, sir. With a history of developmental delay, now presented with sudden onset of abnormal eye movements in the form of vacant staring while sitting in mother's lap, lasting less than 1 minute, followed by sleeping for 20 minutes. Now history of tonic-clonic movements, frothing of mouth. And now history of fever, trauma, recent medication, prolonged cry, or vomiting of overfeeding. They consulted a local hospital and had some investigation and told to be normal and then reassured. Had multiple episodes of similar episodes thereafter, increasing in duration and frequency over days, now around 6 to 7 times per day, lasting 2 to 3 minutes, associated with bluish discoloration of lips, often associated with tonic posturing of all limbs, and then going to sleep. No history of clustering of episodes or diurnal variation. They consulted IMCS for the above complaints and the baby was admitted. Ma'am, can I continue?
Yeah, continue, ma.
Since it is a case of developmental delay, I'm preferring to start from antenatal history. It's a second child of non-consanguineous marriage, spontaneously conceived to a 23-year-old mother and 25-year-old father. Pregnancy detected at 8 weeks of missing periods by urine pregnancy test, and it's a book case with regular antenatal checkup. There was a weight gain of 16 kg during pregnancy, with pre-pregnancy weight was 49 and BMI was 90. In first trimester, folic acid was started after the detection of pregnancy. Dating scans were normal. No history of anemia, fever with rash, lymphadenopathy, drug intake or radiation exposure, and no history of bleeding per vagina. In the second trimester, the quickening was felt at 6 months of gestation. Iron and calcium tablets were taken, and 2 doses of tetanus toxoid was taken. Anomaly scan was told to be normal. No history suggestive of diabetes, hypertension, bleeding PV, or polyhydramnios in mother. In third trimester, mother continued to appreciate good fetal movements, and no history suggestive of polyhydramnios or oligohydramnios, and no history of bleeding or leaking per vagina, and also told to have abnormal position of the baby with head above after scans. In the natal history, born to 39 weeks 4 days gestation with birth weight of 3.2 kg via lower segment cesarean section in view of history suggestive of breech position. The baby cried soon after birth and breastfeeding was initiated within 1 hour of life, and baby was sucking well at breast and was moving all limbs actively. Urine and meconium passed within 24 hours. On day 2 of life, they found to have jaundice and given phototherapy for 1 day and was discharged on neonatal day 3. Thyroid screening was told to be normal and advised to redo hearing evaluation later. No disproportionate large head noticed during that time. After discharge, baby was active, moving all limbs and was feeding well, but noticed to have recurrent episodes of incessant cry lasting hours, many of which required hospital observation and treated as abdominal pain and advised adequate burping, reassured and sent home. These episodes were present until 3 months of age, total around 8 to 10 episodes requiring medical attention. Coming to the past history, at 3 months of age, the mother noticed that child is not attaining head control compared to his peers. Baby was smiling when seeing human faces, but was not able to recognize mother. She was able to follow bright objects and was startling to sounds. History of exaggerated startle present during the early neonatal period, but now it has subsided and there is no exaggerated startle as per mother. Also noticed to have enlarging head size by the neighbors, which mother was not able to identify. At 5 months of age, child attained head control and rollover was not attained. And now she is able to sit with support attained at 7 months of age, and now milestones attained after 7 months. At 5 months, the child started to hold objects when kept at hand, but was not reaching out for objects. Now the child is reaching for objects which was attained at 7 months, and child started to recognize mother at 4 months of age, but is not able to recognize strangers. And child made noises at 4 months of age, laughed loud at 5 months, but is not able to say ma or pa. Also, there is history of loupiness while handling the baby in the form of slipping through hands when held under shoulders, which was noticed since 4 months of age. Baby is able to raise the limbs above the bed and is able to move sideways and is able to kick objects. Now, history of paucity of limb movements or abnormal movements noticed by the mother. Now, history of drooping of eyelids, abnormal eye movements, abnormal position of eyeballs, drooling of saliva or difficulty to close eyes, regurgitation of feeds of swallowing difficulty. Now, history of poor feeding or poor activity, failure to gain weight, prolonged feeding sessions, abnormal body or urine odor, trauma, vomiting, or episodic symptoms. They consulted a general practitioner at 6 months for the above complaints. Neuroimaging was taken and said to be normal. advised physiotherapy and then was reassured. And they are doing physiotherapy on an irregular basis from home and was not followed up. Ma'am,
Leema?
can I continue, ma'am?
Yeah.
Okay. Coming to the
Finish up the
developmental.
developmental history, then we will discuss.
Okay, ma'am. Coming to the developmental history, in gross motor, head control was attained at 5 months. Rollover is still not attained. Sitting with support at 7 months, and there is no sit without support. Developmental age corresponds to 6 months, and developmental quotient is 60. Fine motor is bidextrous reach at 6 months, and monodextrous reach at 7 months. There is no transfer of objects, and developmental age of 6 months with a quotient 60. Social and adaptive milestones. There is social smile at 3 months and was recognizing the mother at 4 months. But there is no stranger anxiety now. And developmental age corresponds to 3 months with a developmental quotient of 30. Speech and language. The baby was able to coo at 4 months and laughing loud at 5 months. There is no monosyllables. Developmental age of 4 months with a developmental quotient of 40. Vision and hearing is normal according to mother. So impression is a global developmental delay with predominant social and language delay.
Dissect your developmental history. Do you consider this as a developmental delay or a developmental stagnation?
Ma'am, here there is a developmental delay with no milestones after
Just
7
go
months.
through the gross motor milestones. If anybody, see, you should have the major milestones, which is the upper limit of normal for each major milestone, which is given in your books. Okay, or you follow any one of your developmental charts in which there are transverse or horizontal bars, so which tells you. Then you can place according to the age of the child, you can place your scale, and whatever is on the left, whether it has been gained or not, or like that you can go through. So anybody who is not developing a head control by 91st day or by the end of 3 months, do you consider that as a developmental delay? Because the upper limit of normal for achieving a head control is 5 months. This particular child has achieved head control by 5 months, is it not?
Yes, ma'am.
10 months, for 10 months age, what are the milestones you expect for this child?
And there should, in gross motor,
You are the only postgraduate who will be answering, or you have one or two other postgraduates as well for your classmates? You are alone. Okay. Tell me that.
Ma'am, here there is gross motor delay. As is, according to the charts, there is no significant delay, ma'am. But there is plateauing of milestones from 7 months.
What are the milestones should have been? What are the gross motor milestones should have been achieved,
Ma'am, at 5 months, the baby should attain head control, and
yes.
And some sitting with
Unsupported
support
should have been achieved. Unsupported. Not
unsupported.
by 10 months, unsupported must have been achieved. And fine motor?
Fine motor, monodextrous reach, ma'am. And immature pincer grasp, immature palmar grasp, ma'am. Palmar grasp.
That's what the child has now. And, by 10 months, you should have heard an pincer grasp, no?
Yes, ma'am. Immature pincer. Here the baby is not having a pincer grasp, ma'am.
Pincer grasp. Whether the child achieved the palmar grasp, reaching for objects.
The baby is reaching for objects at 7 months, ma'am. But there is no
transferring the objects.
No transferring the objects, ma'am.
And pincer grasp has not been achieved.
No, ma'am.
Okay. And then what about the social smile?
The baby is not able to recognize strangers, ma'am.
So by 10 months, you should have attained the stranger anxiety, which the child has not achieved. With the social smile, that itself is little later only. By 2 months, 45 days to 60 days, we should have the social smile. But the child has achieved the social smile. by 3 months. Was it not? And recognize the mother, but yet to develop the stranger anxiety. Okay, what about the speech and language?
The baby is growing at 4 months, ma'am, but there is no monosyllables now.
Okay. What should have been there in for a 10-month-old child in language milestone?
The baby should speak bisyllables. And,
So it seems that gross motor was little okay up to 6 or 7, but beyond that, the child has not achieved anything. Is it not?
Yes, ma'am.
Take the level of 6 months or 7 months. To that, the child has achieved the milestones, whatever the child should have achieved little later, but it's not abnormal. But beyond that, the child has not achieved.
Yes, ma'am.
Is there a stagnation?
Yes, ma'am.
Happened at that
There
point of
is.
time? What happened at that point of time? Whether there was any history suggestive of any infection, anything,
No, ma'am.
or onset of seizures at that time?
No significant history according to mother, ma'am, during that time.
Considering, of course, language milestones, yes, I will rather say there is a delay. The social and adaptive, there is a delay. But considering the motor and all, it seems that there is a stagnation. Okay.
Yes, ma'am.
And what are the other histories you are having?
Ma'am, the child is now admitted with the seizures, ma'am.
Okay. What was the onset of seizures?
Here, since 2 weeks duration, the child is having recurrent episodes of vacant staring about 6 to 7 times per day, ma'am, associated with the
Whether it is a
postictal speech.
myoclonic jerk, whether it is a myoclonic jerk, whether it is a general, what is the semiology of seizure, whether it is a generalized one, focal,
No,
or a
no
myoclonic,
history of
or a
any,
spasm.
no history of any jerky movements, ma'am, during this episode. Only vacant staring.
Did you witness the episodes? Did you go through the video recording of the episodes?
They had a video, ma'am, of vacant staring. In that video, there is no jerks. The child is fixing at some point and not responding to any touch or calls during that period. And the
Whether
baby
there was
was
any
playing
technique,
during
whether
that.
there was any deviation of the eyes, whether there were associated nystagmoid movements, eyelid twitching, or twitching of the lips, or any oral movements, any drooling, all those things did you notice? What was the posture of the child during such episodes, whether the child was floppy or tightness of the limbs? You said
the
there was
video,
some tonic posturing lasting for 2 to 3 minutes. Then whether it was a tonic seizure
in the video,
or whether there
was
were any extensor spasms. But you have said there was no clustering, is it not?
no clustering.
What was the interval between one seizure and the other seizure?
Almost 1 hour, 1 to 2 hours, ma'am.
So it may not be a spasm. So can you tell me what will be the characteristic features of a spasm, infantile spasm? Nowadays it's called epileptic.
There will be flexor spasms and extensor spasms, ma'am. Normally, usually it is flexor spasm occurring in clusters of 2 to 3 seconds and followed by a cry. And it usually has a diurnal variation, more occurs during morning hours after a sleep, ma'am.
After getting up from sleep, there should be a clustering. And these jerks will be lasting for a few seconds. Within 10 to 15 seconds, another jerk will be coming. Literature says the mixed spasms are common, but while in practice, we tend to see more of flexor spasms, as you have said. So flexion of the neck and the flexion of the limbs. Could it be an extensor spasm in this child?
There was no clustering or diurnal variation.
Very good, very good. There was no clustering. That shows that that cannot be a extensor spasm. Okay, very good. And you said there were some symptoms in the postnatal period or in the very early infancy up to 3 months of age. What were those symptoms? What were those episodes?
According to the history, there was an incessant cry and
Mm.
child was inconsolable, requiring medical attention with exaggerated startle responses also. The baby cries for, so it shows an irritability now.
Mm.
Like
Could those symptoms be seizures?
കാണാൻ പറ്റുന്നില്ല സ്ക്രീൻ വെക്കണം അല്ല
Whether they were seizure mimics?
ma'am, it can be seizures because newborn seizures are subtle seizures which we don't get
At what age did the
tonic-clonic
child have
movements.
all these symptoms?
From after discharge,
What
10
age?
days after discharge, the child presented with irritability and
So
incessant
by
crying.
12th day of postnatal life or by 15th day of life, the child had. Is it so?
Yes, ma'am. Yes, ma'am.
Whether they were associated with any stimulus like touching the nose or touching the face, tapping the face or tapping the nose.
There is no history like stimulus, ma'am.
These things were
But,
there.
the baby
Suppose you
had
develop such
exaggerated
jerks when you are tapping the nose or tapping the forehead. Then what do you call that?
jittering, shuddering,
No. Shuddering attacks in 3 to 4 months of
3
age.
to 4 months.
Jitteriness is your stimulus sensitive, of course, in the newborn period only. How will you distinguish between a jitteriness and the true seizures?
Jitterness will subside with the like touching,
With
ma'am.
restraint.
Yes,
If you hold the limb which is jittery, then immediately the movement will disappear and there are
Subside.
no associated autonomic symptoms. It is stimulus sensitive as yours. And the movement will be like a tremor like.
Yes,
Whereas in seizures, what are the type of seizures you can have in the neonatal period?
They are
Do
subtle
you get a
seizures, ma'am.
generalized tonic-clonic seizures? Do you get
Less
a generalized
likely, ma'am.
tonic-clonic seizures? Less
Less
likely.
common,
What are
ma'am.
the types of seizures? Yes. What
There
are the
can
types
be
of seizures you can have?
subtle seizures like cycling movements,
Very good.
vacant stares,
Mm.
unilateral limb
What else?
movements.
Focal clonic. Then subtle seizures is the commonest. Focal clonic. Then
Gaze
what are the other
abnormality,
types?
ma'am. Gaze abnormality.
Gaze abnormality and all will come under subtle itself. There are 5 types of seizures you can expect with the newborn. One is subtle seizure, which is the commonest. Next one is the focal clonic. Then
Tonic,
tonic, very good.
myoclonic. Then
Myoclonic, very good.
Then,
Multiple, the clonic seizure, if it happens in only one limb, you call it as the same limb, you call it as a focal clonic, or it can be multi-clonic actually. Okay. So these are the 5 types of seizures you can expect. So only you need to see the seizures or check the semiology in the newborn period.
there was no video of the period, ma'am. But
The thing is, if you happen to see a type of seizure, then you can have some clue about the etiology. Okay, suppose the child is developing a focal clonic seizure in only one limb, then you have to rule out the vascular cause for that particular child. So it could be your ischemic stroke or hemorrhagic stroke for a focal clonic. Okay. Suppose there are only myoclonic seizures, then it tells you that it could be a metabolic etiology. So you have to rule out IAM in that particular newborn. Suppose you happen to see tonic seizures in the newborn, then you have to rule out structural pathology in the brain, especially developmental anomalies of the central nervous system, such as your pachygyria lysencephaly, otherwise called pachygyria complex. So, from the semiology of the neonatal seizure in the newborn, you can have a clue about the etiology and investigate accordingly. Whenever there is a tonic seizure, then immediately you have to take an MRI brain. Similarly, focal clonic, you have to do an MRI brain, including MRA and MRV. Whereas if it had been a myoclonic seizure, your choice of investigation will be ruling out an IEM, so you will be doing a metabolic outcome. Okay, that's why seeing the semiology, finding out the semiology is important. Okay, whether could this be a tonic seizures at that point of time?
There is no
There
history of any
wasn't,
posturing during that episodes, ma'am.
mm, mm, mm.
There is a history of incessant cry only.
Did you ask that these episodes were associated with feeding?
Not associated with the feeding, ma'am.
Suppose these episodes occur just after feeding, sometime after feeding, within 30 minutes. What is your diagnosis? Which seizure mimic will you consider? What is Sandifer syndrome, dear?
Self-gratification, 100%.
So all these things should come to your mind, and whether these tonic activity or tonic substance were frequent, they were frequent, and what was the frequency like, and afterwards you said that these symptoms they disappeared, is it not?
Yes, ma'am.
Whether this was an exaggerated, you said something about exaggerated startle as well.
Yes, ma'am.
What was the timeline for symptom?
The says in the newborn period, there was exaggerated startle 3 to 4 months now. And then there was no such episodes. The baby was
No such episode.
startling
Okay.
to very low sounds.
How do you distinguish between a normal startle? See, normally also children will, these newborns and young children will be having a startle, is it not? Infants.
Yes, ma'am.
So how do you distinguish between a normal startle and an abnormal startle?
There is extensive response in abnormal startle, ma'am.
Very good.
And flexor
Whereas in a normal
response
startle, it is a flexor response.
flexor
Yes.
response. And there will be adaptation in a normal startle,
Very
ma'am.
good. Very good. These are the two important points to distinguish between a normal and an abnormal startle. So whenever you are having an abnormal startle, what are the conditions will run into your mind?
Ma'am, GM2 gangliosidosis, seizures.
Yes.
Then Krabbe's disease, adrenal Krabbe, pyridoxine deficiency.
Pyridoxine dependency as well. Okay. So these are the conditions you have to consider. And these symptoms were in the newborn period, within 1 month of life itself, is it not?
Yes, ma'am.
From the 15th day of life up to 3 months of age.
Yes,
So, out of these 4 conditions you said, what could be what are the possibilities you can consider? What would be your order of priority?
Pyridoxine dependency issues. Then Krabbe's disease, and then GM2 gangliosidosis.
You also said that there was some irritability and incessant cry, is it not?
Yes, ma'am.
Suppose
Irritability will suggest a neurodegenerative disorder. Can suggest a
irritability,
neurodegenerative or
incessant cry, it can be due to your ICP, increased ICP also. Is it not?
Yes, ma'am.
And it could be an early sign. It could be a sign of your early CP also, early sign of CP also. So those things you have to think about in this particular case. And what else you have said? What are the other positive histories you have told?
There is floppiness, ma'am. And
in your history of presenting illness,
and enlarging head size.
Yeah. So you have said the mother felt that there was a generalized floppiness of all limbs, is it not?
Yes, ma'am.
Since when she has noticed, since newborn period itself, or from 3 months or 4 months or 5 months?
Since 3 to 4 months, ma'am.
3 to 4.
More than the mother, grandmother was able to tell about the floppiness, ma'am. Was able to.
Okay. So for that also you have to dissect and what could be the cause? What are the possibilities you have to consider?
Excessive floppiness means hypotonia, ma'am. It can be a central cause or a peripheral cause. Since there are associated other things like seizures and all, we can consider central cause.
Central cause, very good. So in a peripheral cause, you may not accept your CMD, as your congenital muscular dystrophy or mitochondrial disorders. In other things, you will not expect, or you can have seizures associated with that. So you are thinking a central cause for this hypotonia. Very good. What is the other symptom?
There is
Somebody has noticed a
macrocephaly.
large head.
Yes, ma'am.
Is it not? Yeah.
Yes, ma'am.
So at what month they noticed the large head? Was it present at birth?
No, ma'am. During birth, they haven't noticed a disproportionate head size. It was normal. And they told to have an enlarging head size at 4 months by a neighbor, ma'am.
Okay, so
They
that
haven't
also we have to
noticed it.
consider.
Mm.
Okay. And you have said in the, excuse me, you have said in the postnatal history that was some jaundice. What could be
There
the
is
cause of the jaundice?
there is
What
no
was it? It was an
incompatibility
single
setting.
surface phototherapy or a double surface phototherapy?
Single surface phototherapy for 1 day, ma'am.
Was it a pathological jaundice or a physiological jaundice?
It's a physiological jaundice, ma'am. It occurred after
Hmm.
24 hours.
Hmm.
And there is
Were you able to get information about the level of bilirubin?
no, ma'am. They
Or
are not
from the
aware of that.
history itself, whether the forms and souls, what about that yellowish discoloration of the parts of the body which were involved from that? Did you get any other information?
Jaundice was present on legs, ma'am, according to the mother.
And a single day phototherapy was sufficient to resolve all those things. Was it
Yes,
not?
ma'am.
By the history.
Yes, ma'am.
Okay.
By the history,
What are the histories will you ask? Suppose you are suspecting a bind. Does bilirubin
yes,
induce neurodegeneration in a newborn?
ma'am. Is there any history of like what was the duration of jaundice? What was the like onset of jaundice? Whether it was pathological, first stage cells, any incompatibility?
For chronic stress, what are the histories you will ask? Any irritability, incessant cry,
Irritability, incessant cry, and tone abnormalities.
failure of taking feeds, then opistotonic posturing.
Yes,
Okay, these are the
yes,
4
ma'am.
questions you have to ask to consider whether could it be a bind or not. As per your history, as you have said and nicely pointed out, the mother's blood group was A positive. So you were not thinking in terms of any incompatibility, and this jaundice occurred after 24 hours only, and it was resolved with a single day's phototherapy as well. So you are not giving any importance to that jaundice. Is it so?
Yes, ma'am.
Okay. And what are the other things in the history to be considered, or other negative histories?
There was no any positive
Here you are
movements.
having a delay plus a stagnation, and you are
Yes,
having a child with, and the second most important thing is seizures. Then what else? Generalized,
macrocephaly.
there is a floppiness, and the child is not. What about the vision in this particular child from the
The baby
history?
was able to fix and follow light, bright objects, ma'am. Vision is normal
Okay,
according to
but
mother.
not regarding the face.
Hello?
Whether the child is able to recognize the.
Yes, ma'am. Social smile was present.
Okay.
The baby was able to recognize human faces.
Okay. Okay. Then you said something about the tone. There was a floppiness noticed by the mother. Was there any weakness? Any
No,
other part
ma'am.
of the
Baby
you said
was
about that it is a central hypotonia. Okay, fine. And any other part of the neuraxis is involved,
no,
like whether there is a weakness of limbs? Are there
no,
any
ma'am. There
involuntary
is
movements?
no
No. Are
involuntary
there
movement of positive.
any history of clumsiness of movements?
No, ma'am.
Okay, very good. Were there any history suggestive of cranial nerve dysfunction?
There is no history of any drooping of eyelids or abnormal
That and all you have
drooling of
told. So
saliva.
there was no history suggestive of cranial nerve involvement, is it not?
Yes, ma'am.
Most important thing in all these cases is about vision, hearing, about feeding. What about the
Yes, ma'am.
feeding? Is there
The
any
baby was
swallowing difficulty?
no, ma'am. The baby was able to suck well. There was
Mm.
normal duration of the feeding time. There is no
Very
swallowing
good.
difficulty also.
No history of any swallowing difficulty, is it so?
Yes, ma'am. No.
Okay, so there is history wise, there is no history suggestive of cranial nerve dysfunction at all. Anything else you have to ask? Any other thing?
If there is
Because from
any
the
brain
history
cells,
itself, you have to come to a conclusion what could it be so that we can confirm those things in the examination.
Yes, ma'am. If there is any history of raised ICT features like vomiting, ma'am.
Whatever
then
we have discussed so far is about the where is the lesion or what could be the structures involved in this particular case. Now we have to get the etiological history. So
Yes,
you
ma'am.
have said there is a delay and there is an the floppiness, and you have said there is some amount of a large get somebody has noticed but mother has not felt. And there are seizures. These are the 4 things which are important in the history, is it not?
Yes, ma'am.
So what could be the etiology? So what are the etiological histories so far you have asked?
Whether there is any vomiting or abnormal position of eyeballs, ma'am.
Tell me what are the causes for developmental delay plus seizures?
There can be
So
infective
these are the
causes.
2 major points, is it not? Then
Yes,
after
ma'am.
the examination, we will confirm whether there is a hypotonia or not, whether there is a microcephaly or macrocephaly is there or not. All those things we will confirm. Now the
Yes,
two things which are gross problems in this particular child is a delay plus stagnation, and there is a seizure.
Yes,
That
ma'am.
much is sure. So what
Yes,
are the
ma'am.
causes for such a combination?
Since there is stagnation of milestones, I will consider a progressive neurological disorder, ma'am, first. Then
Could it be
there
an
can be high.
Can
Hello?
it be a intrauterine infection, developmental
Yes.
delay plus seizures?
Usually it presents with a small head size, ma'am, and there is
Do
no
not
history
think
of any
about this case. Do not think about this case. First of all, you just have a list of diseases for these 2 problems, developmental
Yes,
delay
ma'am.
plus seizures. What
Yes,
could
ma'am.
be what are the causes, possible causes for this combination, developmental delay plus
Yes, yes,
seizure?
yes. It can be intrauterine infection, ma'am. It can be a
Okay.
sequela of NNS, neonatal hyperbilirubinemia, or it can be any perinatal asphyxia, ma'am,
Do
causing.
you develop seizures? In extrapyramidal CP, do you develop seizures? The incidence of seizures in extrapyramidal CP is very less.
Yes, ma'am.
Okay, so you do not consider that one. Could be
Yes.
HIE sequelae or in the neonatal period, something like a hypoglycemia which can cause this combination. Yes.
Mm.
Or any vascular insult in the newborn period. Okay.
Yes,
What are the
ma'am.
other conditions that can cause this combination? Developmental anomalies of the central nervous system, is it not?
Yes,
Initially
ma'am.
itself we said that is a lysencephaly or
Mm.
your schizencephaly. Such things can cause these problems. Okay, so developmental anomalies of the central nervous system, intrauterine infection, something in the newborn period like a HIE sequelae or a hypoglycemia sequelae, or in the newborn period something like your meningitis, neonatal meningitis, encephalitis, and then any vascular insults in the newborn period. Anything else?
Mm.
Anything else? Can
Any,
inborn errors of metabolism can cause this combination?
yes, ma'am.
Yes. Developmental delay plus seizures, inborn errors of metabolism can cause. What else?
Then if there is any untreated hypothyroidism in the mother,
Okay. Hypothyroidism
uh,
cannot cause seizures. Developmental delay? Yes. Seizures?
less likely.
Less likely. Very good. Then, what are the other possibilities? Mitochondrial disorders, peroxisomal disorders. Then, your LSDs, early infantile LSDs, lysosomal storage disorders.
Mm.
So these are the list of diseases which you should have for this combination of symptomatology. Okay. Then from the history itself, what are the things you can rule out?
There is no
Do you
history of
think
any.
in the antenatal period, were there any history suggestive of intrauterine infection?
No, ma'am.
No, but still
No.
it can be a mild infection, so we cannot totally rule out that condition, is it not?
Yes, ma'am.
We have to keep that possibility as well. Can you consider this particular child to have an HIE sequelae or hypoglycemia sequelae, neonatal hypoglycemia sequelae, neonatal vascular insult sequelae, neonatal meningitis or encephalitis with a sequelae?
The baby was not having any history
No,
of that.
because the neonatal transition was smooth except this 1-day phototherapy, which was considered to be a physiological jaundice. Otherwise, initial part of the neonatal period was okay. But after that, 15 days later, the child had some symptomatology, but was not considered as a seizures, never admitted, never investigated. Is it not?
Yes,
There was some history suggestion of exaggerated startle, which disappeared afterwards. So that particular history is very important. Okay. So suppose that if you are giving much importance, you have to consider that history. So considering that history, what could be your possibilities among these conditions?
can be a neurodegenerative, early
infantile,
lysosomal
LSD.
storage, LS.
Yeah, LSDs. Okay. And whether pyridoxine dependency also, you got it. IEM la, among the IEM, in which you can have an exaggerated startle. So pyridoxine dependency also you have to consider. Okay, my dear.
Mm.
You will not consider any whether developmental anomalies in the central nervous system will you consider?
That
Suppose a
can be
lissencephaly is there and the child is developing, child is having a developmental delay and the child is having seizures.
yeah, the predominant milestones affected are the social and language milestones, ma'am. Also, there was early development was normal.
More of the thing is the early that point is important. Early development was normal. Okay. So you will not consider developmental anomalies of the central nervous system as a probable cause for this child. Okay. So those things have been ruled out. You can narrow down your etiological causes. Now, what are the other histories have you asked? You have so far come to developmental history. Next history is
The diet history, ma'am.
right
Baby
history
was
and all.
prescribed.
You can whether there is a history of failure to thrive.
No, ma'am. The
No.
baby.
Then is there a gap? Protein calorie gap and all.
There is a calorie of the child is getting a calorie of 270 calorie, ma'am, and required is 300
Okay.
calorie in addition to breast milk. So there is no much calorie gap and protein gap.
Birth weight is 3.2 kg. What is the current
3.2
weight of the
kg.
child? Current weight of the child at 10 months.
8.2 kg, ma'am.
You should have triple by 1 year, is it now?
Yes,
So
ma'am.
not much of decrease weight. Okay. What about your next? The most important next history is your family history. Is there any? What is the order of this child?
The baby is second order, ma'am. Second child of a non-consanguineous marriage.
Okay. What about the first child?
The first child is doing normally. It's a girl child, the 3 years old.
Okay. Is there any
And there
history
is
of similar illness or family?
there is a third degree consanguinity among the paternal grandparents, ma'am. And also there is a history of blindness in the paternal siblings since birth. But there is no intellectual disability or development delay to the siblings, and they are doing well after learning Braille script.
Okay. Now summarize the history. What is the summary slide?
It's a 10-month-old girl, second child of non-consanguineous parish with nil significant perinatal history. Complaints of delay in attainment milestones noted since 3 months, with no milestones attained after 7 months of age. Enlarging head circumference and increased floppiness noted since 4 months, and seizures of 2 weeks duration. There is history of frequent incessant cry and exaggerated startle in the early infancy.
What are the conditions?
Like
Now you will.
Here
Is
there
there
is
any?
a
The most important next question is there a regression?
there is no
Whether the
regression of
child has
milestones,
lost
ma'am.
any milestone which has been attained?
No, ma'am. There is no
No.
regression of
Very good.
milestones.
That's
But
a
there is
stagnation. The child is not attaining any further milestones. Is it not?
yes, ma'am. The child is
What
having
is your
plateauing
thinking?
of milestones for 3 months, ma'am. After 7 months, baby is not attained any milestones with the floppiness, ma'am. So, developmental stagnation with the floppiness will think of a progressive disorder associated with the macrocephaly, exaggerated startle, ma'am. So,
Conditions
I would like to
you
consider
are going to consider.
a neurodegenerative disorder with a predominant gray matter involvement in view of early onset of seizures.
All these
and more
neurodegenerative disorders are called neurometabolic disorders as well. So, what are the symptoms? When will you consider a neurometabolic disorder or a neurodegenerative disorder in any child?
when there is a developmental regression or when there is developmental delay with
Number one is loss of attained milestone, or there's a neuro regression. When will you call a neuro? When will you consider neuro regression? Suppose one particular child has lost the milestones, and a mother is telling for the past 2 months only the child is one by one losing the milestone. Another mother is telling my child has lost the milestone. The duration is for the past 1 year. So to consider regression, what should be the duration? Minimum duration for that. Somebody has experienced a traumatic brain injury,
Okay, ma'am.
was on ventilator, comatose, now has lost everything. Do you consider that as a neuroregression?
It's a
Somebody
pseudo
has been admitted with an encephalitis or a meningitis. At the time of discharge, whatever the child has achieved earlier is now everything is lost. Do you consider that as a neuroregression?
Ma'am, it is a pseudo regression, ma'am.
Very good. So before considering a neuroregression, you should rule out what is called a pseudo regression, number one, and the duration must be at least 3 months to consider this is a degenerative disorder. Okay, so this is the first point, and the second point is much more important is it should be a progressive pathology. Unless otherwise it is a progressive disorder, you will not consider degenerative disorder in any child. Okay?
Yes, ma'am.
Yes. So you are considering a degenerative disorder in this particular child because there is no regression in this child at all, but still you want to consider.
Yes, ma'am. Because there is a developmental stagnation with the gross hypotonia, but there is no any
With an
explained causes.
unexplained generalized hypotonia or floppiness, still we have to think about neurodegenerative disorder or a neuroregression in this particular child. Very good. Okay. What could be the whether it is white matter or a gray matter disorder you want to consider ongoing?
More likely to be a gray matter involvement predominantly because there is early onset seizures. There is more involvement of social and language milestones, ma'am.
It seems that motor milestones are a little bit okay, whereas your social and language milestones are a little delayed, and there is an early onset of seizures. And the third point is
there is exaggerated startle also, which can be seen more in gray matter disorder.
Gray matter. Very good. Anything else? Suppose it had been a white matter, there should be an history suggestive of stiffness of limbs. That so there is a history of floppiness only is there. So you are considering a gray. Very good. You can proceed to examination, general examination.
General examination, the child is lying supine in mother's lap, alert and playful, maintaining eye contact and interacting with surroundings. There is no pallor, icterus, cyanosis, clumping, lymphadenopathy or edema. This is the baby, ma'am.
Somewhat alert only.
She is playful and there is no stranger anxiety, ma'am.
Oh, that's no stranger.
Vitals, heart rate is 110 per minute, regular, normal volume and character.
Everything normal?
Yes, ma'am.
Everything normal? Okay, next slide.
Head to foot examination, the head appears last with hair normal. There is frontal prominence, post facies present, and hypertelorism present. Eyes, there is no ptosis or nystagmus, no cataract or corneal opacities, and no signs of vitamin A deficiency. Oral cavity, there is high arched palate, gum hypertrophy, and there is thick lips. Thus, there is no feature suggestive of rickets. Abdomen is distended, the internal orifices are free. Skin, there is no rash, neurocutaneous markers, or extensive Mongolian spots. There is increased heel pad thickness now, and there is no deformities of spine. There is coarse facies with the hypertelorism. There is high arched palate, gum hyperplasia.
Anything else? Anything else you have to say in the general examination? Go back to the slide. You are told head appears large and there is a frontal prominence. Okay.
Yes,
Macrocephaly with frontal prominence. What are the causes for macrocephaly? Is there a macrocephaly after measuring the resistance?
Yes, ma'am, there is macrocephaly.
Okay. What are the causes for macrocephaly?
Macrocephaly may be inherited macrocephalus, autosomal recessive and autosomal dominant. There can be syndromic causes for macrocephaly.
Macro, medial macro.
Macro.
Yeah.
There can be syndromic causes like Soto syndrome, and there can be neurodegenerative causes like.
What would be the first cause for macrocephaly? Is it SOTAS? First reason for our first cause for macrocephaly. It is hydrocephalus.
Hydrocephalus. Okay. There is no sunset sign, ma'am. Okay.
Oh, hydrocephalus. Then what are the other causes?
Hydrocephalus,
You can classify
megalencephalus.
them as first of all fluid compartment, then brain parenchyma, then skeletal compartment. Like that, you can divide the causes for macrocephaly and tell us so that you will not forget anything. So fluid compartment, yes. CSF compartment, yes. Hydrocephalus, what else? Hydranencephaly. Is it not?
Yes, ma'am.
Oh, hydranencephaly. Then
bony compartment, ma'am.
Megalencephaly. Among the megalencephaly, what are the causes for megalencephaly? What are the
Can be
degenerative disorders? Treatment disorders associated with macrocephaly. Alexander and
Canavan, ma'am.
Canavan. Very good. Among the gray matter disorders, macrocephaly.
There can be Tay-Sachs disease, Santos disease, GM2 gangliosidosis.
So GM2 gangliosidosis.
Then GM1 gangliosidosis.
GM1 and all, you don't have a macrocephaly. Mucopolysaccharidosis, MPS.
MPS.
Okay. Megalencephaly is over. Anything else among the about the bone, skeletal compartment?
Bony compartment can be increased in hemolytic anemias.
Very good. Hemolytic anemia. Any skeletal dysplasias associated with macrocephaly?
Achondroplasia.
It's wide open.
Achondroplasia, ma'am.
It's wide open anterior fontanelle, my dear.
Rickets, ma'am.
Macrocephaly. Did you come across with the pycnodysostoses? Cleidocranial dysplasia. These skeletal dysplasias are associated with a large head. Okay. Then only your cerebral gigantism, which is otherwise called SOTA syndrome. Then lastly, familial macrocephaly. So this would be the list. You cannot say SOTA syndrome as the first cause for macrocephaly in a child. It should be hydrocephalus, hydranencephaly, large porencephaly cyst, then megalencephaly, then skeletal dysplasia. There's a bony compartment, hemolytic anemia like thalassemia. Then your skeletal dysplasias with macrocephaly. Then lastly, SOTAS, and you should end it with this one, familial macrocephaly. So in this particular child, when you have a macrocephaly with a frontal prominence,
we have to think
child with a hydrocephalus with a frontal prominences, you will consider aqueductal stenosis as the first cause. Okay, when there's a frontal prominence. Suppose there is a posterior, your occipital prominence is there, then you have to think about
Arnold Chiari.
Dandy-Walker malformation.
Dandy
Arnold Chiari, occiput will be flat.
Flat ox.
Whereas in Dandy-Walker malformation, the occiput will be prominent. Okay, so that
Yes,
is the thing which we have to consider. And then hair changes, skin changes also we have to consider, we have to check for. What are the other causes for any IEM with macrocephaly? IEM macrocephaly. Inborn erythrometallism with macrocephaly. Any organic ischemia with macrocephaly? Butyric aciduria type 1. They can have chronic subdural hemorrhage. They can have macrocephaly. Similarly, Menkes disease. These are the other two IEMs which you have to consider in a child with macrocephaly. Okay. So in
Okay.
Menkes disease, the hair will be of
Kinky hair.
yeah. Trichocerex nodosa will be there. So that's why hair is important. And you have a coarse faces. What are the causes for coarse faces? Gargoyle
faces.
faces.
Neurodegenerative disorders.
No, I am asking you causes for coarse faces in a child.
It can be hypothyroidism, coarse faces, and there is GM1 gangliosidosis, and it can be MPS.
Always, how many cases of
Mucolipidosis.
GM1 gangliosidosis you have seen, my dear? So the common thing should come first. So MPS will be the first one.
Okay.
Hypothyroidism, yes, it is a treatable cause. It should come as the first one. The next thing should be a MPS, mucopolysaccharidosis. Okay. For coarse faces, it's mucopolysaccharidosis. Other causes, of course, GM1 gangliosidosis. Good, proceed. Any other causes for coarse faces? Any other such storage disorders?
Mucolipidosis.
Mucolipidosis. This rare things like your monocytosis. Okay, so those things are coarse faces. Then hypertelorism, eyes. Anything in the eye? Anything else in the eye you have to mention? Since you have a coarse faces, you have pardon me. Sunset sign, of course, for hydrocephalus you have to. But in this child, you are not considering a sunset hydrocephalus. Suppose this has been a hydrocephalus with seizures. Now the child is presented to you with the seizures and macrocephaly. What would be the other history in the exam, in the history, or which history rules out hydrocephalus in this particular child? Suppose there is a hydrocephalus, you will be having a spasticity in the lower limbs, is it not?
Yes, ma'am.
So this particular child is having a generalized floppiness only. So that tells you that it may not be, this macrocephaly may not be due to hydrocephalus. Then having a coarse faces, we have told just now that MPS can be the cause for coarse faces. So in the eyes, you have to look for clouding of cornea. Okay, that also you have to include. You have written corneal opacity, but clouding of cornea is much more important. Okay, oral cavity, yes. Now you have told gum hypertrophy. So what are the causes for gum hypertrophy in children? Which is the commonest cause for or what are the causes? Tell me.
Drug-induced causes, ma'am.
Yes, very good.
Phenytoin.
Which anticonvulsant cause?
Phenytoin.
Very good. So whenever the child is on a long-term phenytoin, you should always examine the gums to look for gum hypertrophy. Now, pertaining to this case with the developmental delay, seizures, now only the child is having seizures, now only the child is going to the anticonvulsant. So we cannot say that this could be an induced gum hypertrophy. What are the LSDs in which gum hypertrophy can be present?
GM1 gangliosidosis, ma'am.
Very good. GM1 gangliosidosis.
MPS, ma'am. Hurler syndrome. Mucolipidosis.
Mucolipidosis. So GM1 and mucolipidosis, you have to say right. Very good. Anything else? Did you look for any large tongue?
Macrogloss. No
There was any
macrogloss.
macroglassia? There was no macroglassia. Very good. So you have to mention that as well, because you can have macroclasia in MPS. Okay, right. Anything else? Anything? Extensive Mongolian spot you have told. There are no extensive Mongolian or prominent. You have to use the word prominent. Okay. Suppose there were prominent Mongolian spots. What could be your diagnosis among the LSDs? Which LSD is associated with Mongolian spots?
GM1 gangliosidosis.
Very good. GM1 gangliosidosis. Okay. Very good. Then next slide. On the foot examination, you are sure that there is a macrocephaly, and there is some coarse faces, and there is some gum hypertrophy. Otherwise, nothing. High arch palate and all can occur as a part of your dysmorphism. So this much is you are sure. Okay. So we have to consider dysmorphism. Already we have 4 points. So additionally, we have to add macrocephaly to coarse faces as well. Yes. Anthropometry, we will next.
Developmental
In the anthropometry, did you measure the head circumference?
Yes,
and was
ma'am.
it really
50
more than 3
centimeter,
standard
ma'am.
deviation? Okay. Okay. So macrocephaly is confirmed now.
Yes,
Whether AF has been closed?
AF, the inner table is closed, ma'am. The outer table was open.
It is not a wide open anterofontanal.
No, ma'am.
Okay. Next.
Developmental assessment. The pull to sit, there is no head lag and back is straight. In sitting posture, the head is steady, sits with support and back is straight. In ventral suspension, the child keeps head above the plane of the body and it is maintained. In prone position, the head is above the bed. In vertical suspension, the baby slips through fingers. In fine motor, there is immature palmar grasp and no pincer grasp attained. Amyl Tyson anchors increased and there is hypotonia. Nervous system examination. The child is alert, playful, interacting with surroundings and maintaining eye contact. Cranial nerve examination. Olfactory nerve is not tested. Optic nerve. The child is fixing and
The
following
cranial nerves
right.
are normal. All the cranial nerves are normal.
In the
Is there any
vestibulocochlear
abnormality?
nerve, there is no localization to sounds, ma'am.
That side examination of the eighth nerve, you feel that the child is not turning towards the source of the sound.
Yes,
Whether there
ma'am.
is any behavioral response?
No, ma'am.
No. The child is not. How do you look for behavioral response?
When we make a sound, whether the child turns. No, ma'am.
Now, when the child is involved in some other activity, when you crackle a paper near the external auditory meatus, then the child should stop whatever the child was doing earlier and attempts to hear the sound. If not turn towards the source of the sound. At least that should be there. It was not there. Is it so? By this age, ideally, the child should turn towards the direction of the sound. Child is not turning.
The baby was turning after few minutes, ma'am. But was not localized.
Not immediately. Okay.
Not immediate.
Other cranial nerves are intact.
Okay, no, normal, ma'am.
Fundus.
Fundus
is normal.
There is
no pale disc.
There is pale retina, ma'am. Macula.
No, disc failure is different. Retinal abnormalities are different. No?
Ma'am. Here there is retinal.
Case, what are the things we have to look for is whether the disc is failure or not, whether there is any cherry red spot, what about the retina, what about the background of the retina, are there any bony spicules or pigmentation is there to say that could be a possibility of RP. These three things are important. The child is looking, fixing and following light in all directions.
Yes, ma'am. The baby was fixing and following. Yes, ma'am.
Okay. Whether the pupils are equal and reacting to light?
Yes, ma'am.
Very good. So the vision is okay. So you have to check the fundus. You have written that there is some bilateral optic disc failure is there. Is there a cherry red spot? How will you look for a cherry red spot?
through fundoscopy.
Where is the cherry red spot? Fundoscopic
And
only.
the macula, ma'am. Macula, ma'am.
Macula
We
is
will
nasal to your disc or temporal to disc?
nasal.
Nasal.
No,
No,
ma'am.
yeah. It is two disc diameter, temporal to the disc. Okay. What you
Yes,
have to
ma'am.
check this, you have to dilate the pupil. Just look through the pupil. So when the child moves the eyes here and there, you may be able to get a glimpse of that cherry red spot. When you say cherry red spot, is it really looking red? Or what will be the color of the cherry red spot when you look at it? Is it red in color? As you call it, is a cherry red. Go and ask, check whether if you have a child with a cherry red spot in your
Okay.
hospital, kindly you ask all the postgraduates, come and see the child, okay? It will not be red in color, it will be violet in color. In Tamil, what we call it as a Navapal color. It will be a deep violet. Okay? That would be the cherry red spot. If here you have written no cherry red spot. Retina, of course, is difficult for us. It is only from the ophthalmologist opinion. We can come to a conclusion whether retina background retina is normal or is there any RP or not. Okay, very good. Next, spinal motor system examination.
Motor system, the bulk is comparable on both sides. There is no wasting. On inspection, the child is lying supine with arms by the side, hips are abducted and knees are flexed. And palpation, the muscles are flabby to touch. And the tone is decreased in all limbs by passive tone. Power, upper limb, it is almost more than 3, ma'am. All power.
Steps on power is more than 3 in all the 4 limbs. There is no asymmetry. Is it so?
No, ma'am.
There is
No,
no proximal is more weaker like that. You are not able to distinguish anything. But there is
No,
a
ma'am.
generalized hypotonia you have mentioned. Okay, right.
In reflexes, superficial reflexes, conjunctival reflex normal, abdominal reflexes are present. Plantar reflex, bilateral extensor plantar. In deep tendon reflex, biceps, it is 3+, triceps, it is 2+, supinator, it is 2+, and knee is 3+, and ankle is 2+ on both sides, ma'am. There is
It's
no
better to
flawness.
write because what is 2+, what is 3+?
3+ is brisk, ma'am, and 2+ is present.
2+ is
And it is
normal. So it is
normal.
better you can write whether it is present or brisk. You can say whether it present means present. Brisk means
Yes,
brisk or exaggerated, you can write. Brisk or exaggerated, you can use. That terminology would be the best. And among the superficial reflexes, you have to mention conjunctival, corneal, palatal, pharyngeal, abdominal. If the child is a male child, then cremasteric, then lastly plantar. Okay. Do you consider this bilateral plantar extensor is abnormal or normal?
It can be normal or abnormal, ma'am. Since the child is a 10-month-old child, it can
The child
be
is a
seen, ma'am.
10-month-old child. I cannot take it as an abnormal one. If it had been associated with pyramidal findings like your spasticity and suppose the reflexes are very brisk and there is an clonus involved, then it cannot be. Okay. So,
Yes, ma'am.
and if it had been an asymmetrical plantar, one plantar is going down and another plantar is going up, then you can consider that as an abnormal. Otherwise, here I will not take it as an abnormal one in a 10-month-old child. And I have a generalized hypotonia only as per your examination from the inspection, palpation by doing maneuvers as well as by passive movement of the joint. So it was an axial as well as a appendicular hypotonia, is it not?
Yes, ma'am.
Or it is only an axial, is not there only an appendicular hypotonia or both?
Both, ma'am.
And the reflexes on whether they are preserved or brisk, you have to verify. 3+ is brisk. Okay.
Yes, ma'am.
Right, next.
In primitive reflex, there is palmar grasp and plantar grasp, and there is glabella tap, show no adaptation. This is the glabella tap.
Have you examined for exocseptal startle in this particular child?
There is no startle response now, ma'am.
Yesterday you told, did you examine? Did you tap the cot or tap the couch on which the child is lying down? Did you check whether the child is having an
No,
exaggerated
ma'am.
difficulty or not?
No, ma'am.
You can. You have to.
Okay.
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 So it is necessary. Or else tap on the table when the child is on the mother's lap. Tap on the table aloud with your knee hammer, so that check whether the child is going for an exaggerated startle response or not. That you have to mention. Okay. Next.
Okay.
Mm.
Was brisk, ma'am.
Okay.
And Vijay was just present.
Concept you are
Sensory
eliciting in this video.
Hello, ma'am.
In the previous video, what Jeff you were showing?
This was biceps, ma'am. Biceps. Sir.
Biceps. Was it biceps? Biceps or triceps? The biceps. How will you
Biceps,
keep
ma'am.
the limb? How will you keep the limb?
Half flexed, ma'am.
Hmm.
Half flexed and turning.
And the forearm should be in your forearm. Then
It should be
palpate the biceps tendon and then place your thumb of your left hand on the biceps tendon and then strike on your thumb. What you
yes,
have to see is contraction
the
of the
flexion
biceps as well as flexion of the
limb.
forearm. So the position of the limb is not. Otherwise, you keep the hand over the chest of the child.
Okay.
Partially flexed only, not fully flexed. Okay. In between the flexion and extension, you have to keep the upper limb, then tap over the tendon. Yes. Other things in the motor examination, spinomotor examination itself, there are no involuntary movements you have to say. There is no dystonic posturing or choreatitosis. So, no involuntary movements you have to say. Did you offer any object to the child, whether the child was reaching the object or not?
The baby was reaching for object, ma'am.
Then you can assess the this one appendicular ataxia, is it not? How the child approaches the target, you have to just move the target with your toy. With the toy in your hand, you have to move the toy here and there so that when the child approaches the target, you have to find out whether there is any clumsiness or not, whether there is any particular or intention tremor is there. This is how you have to check the cerebral arsenal in this child.
Okay.
Suppose the child is not reaching for object itself, or when the power is less than 3, you can say cerebral signs or disciplinary ataxia or incoordination cannot be tested. When the power is more than 3, you have to check the coordination. Okay. Other cerebellar signs, if there is an titubation, you can mention. If there is a nystagmus, you can mention. There is no titubation, there is no nystagmus, and there is no appendicular ataxia. Whether the child, did you make the child to sit or not? When you made, when the child, whether the child is able to sit when made to sit?
Yes, ma'am. With the support, ma'am.
With the support only. So we
With the
cannot
support only.
consider, we cannot look for truncal ataxia and all. So that and all is not possible. So you can say there is no appendicular ataxia and there are no involuntary movements. Yes. Sensory system, child is able to perceive pain sensation. Okay. Cerebellar signs. Okay, ma. You have mentioned no titubation, no nystagmus, symptoms. Very good. Next.
Examination of CAT. The inspection, abdomen appears
No, the previous
distended.
slide. No, the previous slide. The previous slide. No. Fine, no deformity. Very good. Fine cranium. Where is cranium? Where you have mentioned? You have mentioned only in the anthropometry. You have mentioned about the head circumference. Here also you have to. The last line. Suppose the child is able to stand on rhombox, you have to check. Otherwise, cerebellar signs, meningeal signs, spine, no deformity. Here also you have to mention the cranium. The head circumference is large. Okay.
Okay.
Limbs normal, no contraction. Okay. Limbs contractions and all will come in the general examination, my dear. Spinal cranium, with the spinal cranium, the central nervous system examination will be over. Okay. Right. Other system.
Gastrointestinal system. Inspection, the abdomen appears distended with hernial orifices are free. Palpation,
There is
abdomen is
splenomegaly.
Yes,
That is
ma'am.
hypothalamic. Okay. This is not
Yes,
just a push down liver, something like that. That is a hypothalamic. Okay.
Hepatitis
Liver is
mellitus.
4 centimeters. Okay. Firm consistency you have written. So there is an
Yes, ma'am.
hepatosplenomegaly. That's an megaly. Very good. Next. Other systems, CVS and RSS, normal. So to
No, ma'am.
summarize, after examination,
After examination, the child is allowed with stable whites, having 4 species with macrocephaly and gum hypertrophy. There is global development delay with the predominant language and social
in the
milestones.
general examination, 3 points. On macrocephaly, 4 phases first.
Yes, ma'am.
Dysmorphic, but 4 phases.
Course.
And macrocephaly and
Gum
with the gum
hypertrophy.
hypertrophy. Okay.
Global
Neurological
developmental delay.
examination reveals. Neurological
Generalized
examination
hypotonia.
reveals. Then is
Generalized
hypotonia
hypotonia with the brisk reflexes. Bilateral
with the
extensor
preserved
plantar
reflexes.
response.
Whether this is an brisk reflex or not, you have to counter check. Okay.
Okay.
Brisk reflexes can occur even in a hypotonia, but here you have said only the biceps and the knee are brisk. The other reflexes are just.
Yes.
The other things are 2+ only. There's no clonus. So you cannot
clonus.
categorically say that this is a brisk reflexes and there are no features suggestive of pyramidal signs in this child. The tone is hypotonia. The reflexes are there, but there is no clonus. When will you consider a reflex abnormal, my dear?
If it is associated with the clonus, or if it is not elicitable one, or if it is more
Abnormal,
than
okay. When will you consider a reflex as an pathological reflex?
if it is an
When the
exaggerated
reflexogenic
reflex.
zone is when the reflexogenic zone is increased, even if you are tapping somewhere else also, you are able to get the reflex. And as you said, if it is associated with the clonus, then this is an abnormal pathological brisk reflex or exaggerated reflex. Okay. So here, some of the reflexes are only 2+, they are present only, and 2 reflexes are only brisk. So you have to counter check as well, and we cannot attach much significance to this only to brisk reflexes, since there is only a generalized hypotonia and there is no clonus, as well as the plantar extensor. But in this child, that can be considered normal, since there is no associated spasticity during this reflexes as abnormal reflexes. Okay, that is but the most important thing is the reflexes are preserved. They are not absent. If it had been an absent reflexes, then I have to consider this as either a peripheral hypotonia or a combined one. Since the child is having a seizures, it is a combined one.
Yes.
Okay. So here, since the reflexes are preserved, I can take this hypotonia as a central hypotonia. Very good. Okay. Do you think that there is any weakness of the limbs?
No, ma'am. There is no weakness.
Best observed is more than 3. There is no asymmetry, so you are not considering any weakness. So there is a central hypotonia. Then anything else?
Primitive reflexes are present, ma'am, and hearing loss is
Which
present.
primitive reflexes are present?
There is plantar grasp, palmar grasp, and glabellar tap, ma'am.
Glabellar tap is, we consider that as a release reflex only.
Yes, ma'am.
Okay. Another thing, what you told? Palmar grasp. Palmar grasp is present. Okay.
Plantar
Again, whether
grasp is
there is a
also
groping response, did you look for palmomental?
palmomental. I tried, ma'am, but I was not able to.
Again, this
child
palmar
was
grasp can be a groping reflex, which can be considered as under your release reflexes. Okay. Whether there is a persistent Moro or ATNR?
No, ma'am. There is no Moro reflex.
No.
No ATNR.
No ATNR. So you have a central hypotonia after your examination, and you have confirmed there is a macrocephaly, definite macrocephaly is there. And apart from that, what else after examination? This is the other important point you have added.
Hearing loss. And fundoscopy showed bilateral failure.
You have a suspicion of a hearing loss, the eighth nerve, bilateral eighth nerve involvement, and you have a disc failure. Though the vision is okay, there is a bilateral disc failure suggestive of bilateral optic atrophy. And then what else? The most important thing you have added after
Hepatosplenomegaly.
examination. Very good. That's an argument. Okay. So with all these findings, there is a developmental delay with the stagnation, and there is a central hypotonia. The history suggestive of exaggerated startle, but on examination you should have checked. And after the examination, you have a child with microcephaly, with the central hypotonia, with the preserved reflexes, with the organomegaly and bilateral disc failure, plus or minus hearing loss, hard of hearing or hearing loss. So now, after examination, what are the conditions that you are going to prioritize?
It's predominantly gray matter disease with the macrocephaly and exaggerated
You said
startle.
the child is active. You are looking at the mother. You consider
Hello,
the
ma'am.
mental function. But the child was looking at the mother, smiling at you.
The baby was smiling at all, ma'am.
But the mentation, you feel that cognitive milestones are not up to the age, is it not? And has
Not
not
up to the
attained
age,
the
ma'am.
stranger
There is
anxiety.
no stranger anxiety, ma'am.
Okay. Then, so you are considering a gray matter degenerative disorder? Yes.
Yes, ma'am.
Proceed.
Predominantly gray matter
In
disease,
view of,
ma'am.
in view of,
In view of early onset of seizures, there is more cognitive and social milestones affected more than the gross
more
motor
cognitive
milestones.
and language milestones are affected, social and adaptive and language milestones affected rather than your motor milestones. Next is?
There is no human signs, ma'am. Spasticity. There is floppiness, ma'am.
There are no long track signs to say that it could be a white matter disease. Yes. And there is history suggestive of exaggerated startle. And most important thing is organomegaly. Do you get an organomegaly in white matter degenerative disorder?
No, ma'am.
No, never. No, never. The answer should be never. So
Okay,
you are considering a gray matter degenerative disorder. So what are the gray matter disorders which can occur or which have an onset in infancy? This particular child, something happened earlier up to, 6 months or 7 months, okay. After that, nothing is achieved.
Yes, ma'am.
Though there was a delay, there has been some attainment of milestone, but after which the child is not attaining anything. Was it not?
Yes, ma'am.
So, how do you classify the degenerative disorder? One classification is your white matter and gray matter. And another is according to the age of onset.
Answer, ma'am. If it is less than 2 years, more than 2 years, or more
Can
than
you
5 years.
enumerate the gray matter degenerative disorders?
Yes, ma'am. Gray matter disorders can be with hepatosplenomegaly and without hepatosplenomegaly, ma'am. Ma'am?
Tell me. Proceed.
Okay.
Just name the disorders which come under the gray matter.
With hepatosplenomegaly, there can be GM and gangliosidosis. There can be Santoff disease. Without hepatosplenomegaly, there can be Tay-Sachs disease. Then mucopolysaccharidosis. Then mucolipidosis. Sialidosis, ma'am.
Fucosidosis, monocytosis, all those things will come under this gray matter only. Then anything else? Any other group?
Then neuronal ceroid lipofuscinosis.
Very good. Neuronal ceroid lipofuscinosis.
Then Niemann-Pick disease.
Very good. Niemann-Pick, Gotcher. That also you have to consider under hepatosplenomegaly. Anything else? Don't forget about Alpers and Rett syndrome as well. Okay. All these things will Rett syndrome. All these things come under gray matter degenerative disorder. Okay. Right. Now, for this child, what will be your priority? Among these disorders, which is your first choice or first probable type? So considering a
GM1
grammatic disorder
gangliosidosis,
in
ma'am.
view of organomegaly, you are considering a lysosomal storage disorder, especially because of the exaggerated startle. Though there is, you are not able to find out any cherry red spot, you are considering a LSD, this particular child. So, which LSD is your first choice?
GM1 gangliosidosis.
Why?
Santoff disease.
Which one? Which one first?
Santoff, ma'am.
Tell me,
No,
you tell me, this is my first probable diagnosis in view of this. My second diagnosis is this because of this.
ma'am, first I will consider
Now take,
GM1 gangliosidosis, ma'am.
Why? Good, why?
Because it is a grammatic disease with post-species and gum
The point is
hyperplasia,
core spaces.
exaggerated.
The point is core spaces. Okay, points for your diagnosis. So GM1, GM2, all these things you will consider. Mucolipidosis, all those things. But first choice will be an. Do you consider Sandoff in this case? GM2 among the GM2. Suppose
Yes,
since there is some splenomegaly, do you consider Sandoff?
Sandoff can be considered, ma'am.
Yes,
Because there
Sandoff
is
also. Sandoff also can have abnormal faces or your core spaces. Okay. Suppose you say GM1. What is the point against?
there is
You have a core spaces, that
macrocephaly.
is a far point.
Macrocephaly is not.
Macrocephaly, of course, in all storage disorders, as the material, storage material, it gets stored up, you can develop, but not that much common. That is one thing. Anything else?
There is no cherry
Usually in
red.
GM1, cherry red spot, of course, GM2 also, it is very important, no? What is the percentage of GM2 gangliosidosis will have a cherry red spot? What is the percentage of children with the GM1 will have cherry red spot?
In GM1, 50% of the children.
Very good. It is around 50%. In GM2, it is around 90%.
Almost 90.
Okay.
Yes,
Yeah.
ma'am.
So 90 to 95% we can say. So which is the point? The point for GM1 is your core spaces. Point
Yes, ma'am.
against GM1 is there are no prominent Mongolian spots.
Yes, ma'am.
Okay. Prominence Mongolian spot is a feature of GM1. Okay.
Okay.
So you have to discuss it. Coming to GM2, exaggerated startle. Suppose exaggerated, the exaggerated for exaggerated startle, the first diagnosis will be GM2.
Yes, ma'am.
The next one only will be GM1, then Krabbe, then pyridoxine dependence. Okay. So in such a scenario, there was a very, very early on, so very, very early history suggestive of exaggerated startle response in the early infancy. So GM2 will come first. In GM2, since there is organomegaly, it cannot be tasted. It can be Sandoff.
Santoff.
In Sandoff also, you can have some amount of this gargoyle faces or horse faces. But gum hypertrophy
Usually not
will
seen,
be
ma'am.
for GM1, usually not seen. So for GM1, it is gum hypertrophy. Okay, in that you have to say. So it could be a GM1 or a GM2. Any other thing? Do you consider Niemann-Pick or Gotcher in this particular child?
Niemann-Pick, it can be Niemann-Pick, but exaggerated startle, macrocephaly. I'm not seeing Niemann-Pick disease, ma'am.
Niemann-Pick A or B or C?
Niemann-Pick, mostly it is A, ma'am. It is neuropathic, ma'am.
The answer is A, neuropathic. B is non-neuropathic. C is the entire clinical picture is different. Okay.
Different.
So if it had been a Niemann-Pick, which history can be for Niemann-Pick?
Hepatosplenomegaly and
Examination that is hepatosplenomegaly is for everything. For every LSD, yes.
then
Some tonic things you said, no? Tonic seizures or tonic spasms.
Yes, ma'am.
That is a point for your Niemann Pick. Okay. Could it be a
Okay.
Gotcha?
If at all Gaucher's 2, ma'am.
You get an
It
exaggerated
can be, ma'am.
startle response or a cherry or cherry spot in Gotcha. Do you get a cherry spot in Gotcha?
No, ma'am.
No. Okay. So for exaggerated startle response also no.
No, ma'am.
So your order of preference will be GM1, GM2, and then infantile Niemann Pick. Anything else?
Sialidosis.
The course phases. Do you consider MPS in this particular case? You are having a
Hurler
course phases.
can
You are having a hypersplenomegaly. Do you consider you have a large head? Everything fits in with the MPS.
There is no
You consider
skeletal,
MPS in
there is no bony deformities or skeletal changes.
that is particularly seen only in Marcus type 4.
It can be mucopolysaccharide ma'am. Hurler.
Oh, my God. You had some seizures. Then you have this exaggerated startle that and all can happen. Yes, no? So other things, if you want to consider in view of your macrocephaly or your course phases with the hypertrophy and all, mucolipidosis will be your next differential, mucolipidosis. Okay. So these are the differentials you can consider in this case. How do you want to proceed further?
Investigations, we will do a CBC, ma'am, routinely. And in CBC, we can have
Other
anemia and
differentials, what we are
thrombocytopenia.
having is GM. What are the differentials we are having now? GM2,
GM1,
GM1,
GM2, Niemann Pick,
Niemann Pick, and
then
mucolipidosis are the
mucolipidosis.
differentials we are. Any other degenerative disorder, grammar degenerative disorder we are considering here? No. So only LSDs we are considering right now. So what are the specific investigations you want to do, or the basic investigation? Which investigation is giving you maybe a supportive clue like that? In
One is
CBC or in
optal
peripheral smear,
evaluation.
you want to
In
see what are the things you want.
In peripheral smear, there can be vacuolated lymphocytes in GM1 gangliosidosis
Very
and
good,
Gaucher's.
very good.
And there can be sea blue histiocytes in Niemann Pick disease.
In peripheral smear?
No,
Is
it's
it in
bone
the
marrow.
peripheral smear?
It's
In
the
the
bone
bone.
marrow.
How do you distinguish the home cells in or your storage cells of Niemann Pick and Gaucher in the bone?
It is pass positive in Gaucher cell, ma'am. Gaucher. It is
PAS positive. You have to say
positive.
periodic shift. PAS positive in
Positive.
Gaucher. And it is
And
otherwise
in
called
Niemann
the
Pick,
name of the home cell is sea blue histiocyte. In Niemann Pick,
Sudan black, positive.
it is PAS negative, but Sudan black positive. You have a wrinkled paper like a cytoplasm. Okay. So
Yes.
these things they will ask whenever you are presenting such case. Then, so these are the things either in the you want to do bone marrow for this child to looking for this alone?
No.
No. Okay, right. Okay.
Then
In your peripheral smear, there you may see an atypical things. Yes, vacuolated lymphocytes. Yes. Next thing is
neuroimaging, ma'am.
why do you want to do a neuroimaging? The neuroimaging will give you a clue about the diagnosis.
Usually white matter disease.
For a white matter disease, yes, it is very important because by the pattern of white matter involvement, you are going to diagnose whether it is leukodystrophy or a Krabbe or a ALD like that. But in gray matter degenerative disorders, these findings will be mostly non-specific. What are the findings? Suppose you take an MRI, what are the findings you expect in this child? You may see some involvement of the thalami, or there can be a anything specific. Will you look? Can you have? No. The MRI will not help you in the evaluation of this particular child. Before that, what are the among the basic investigations itself? What else can give you a clue? A skeletal survey is very important.
Yes, ma'am. Yes, ma'am.
Okay. You have said that there is a post phases. You have said that this could be a GM1 gangliosidosis or it could be a mucolipidosis. So by doing a skeletal survey, if you happen to see disastosis multiplex, that is the X-ray findings which you see in an MPS, then it is
Yes.
more in favor of a GM1 gangliosidosis. Suppose the skeletal
Yes,
survey
ma'am.
is normal. You can say this may not be a mucolipidosis or a GM1. I will vote for GM2.
Okay.
Okay, that is number
Yes,
one. The third
Yes.
investigation will be an ophthalmologist's opinion.
Yes.
An ophthalmologist's opinion has a very important role in this particular child. You have to write, whenever you are writing the reference itself, you have to say this particular child is having a global delay with the stagnation, with the macrocephaly, with the exaggerated startle response, with the hepatosplenomegaly, or an expert opinion, or fundus examination to rule out cherry red spot to see macular degeneration is there or not, and are there any RP findings or not? This is what you have to ask. Okay, so a detailed
Okay.
ophthalmological examination will give you a clue. Suppose there is a cherry red spot, you can take away this Gardner and all, rule out Gardner and all. You can keep first possibility GM2, of which is standoff, and then GM1. Then, if at all, if and even. Okay.
Yes, ma'am. Yes,
So,
ma'am.
presence or absence of a cherry red spot is very important in this particular case. Then, anything else? You can do an ultrasonogram abdomen to verify whether how is the liver, how is the spleen, and all that you can do. And if the child is having a seizure, so you can do an EEG as well.
Easy.
Okay. Then,
Yes, ma'am.
then,
Then the
what do you want to
confirmation.
do? Whether you go for the genetic testing straight away, or you want to do an enzyme analysis. If an enzyme
Enzymes.
analysis, again, what are the enzymes you will look for?
GM1, it is beta galactic.
Yeah. Suppose you are doing an enzyme, say you have to do 3 or 4 enzymes, is it not? So it is
Yes,
better
ma'am.
that you go for a genetic testing
Genetic
straight
study.
away so that you can find out the diagnosis. Okay.
Yes.
So WES will be, that is whole exome sequencing will be an ideal choice for this child. Right? And apart
Okay.
from that, and anything else you want to do? Suppose it comes as GM2 or GM1.
Yes, ma'am.
So will you manage this child?
There is
Or
only
to put it in the other
supportive.
way, what are the conditions in these storage disorders for which enzyme replacement therapy is available?
Then Gaucher's disease, ma'am. Then
Very good.
mucopolysaccharidosis, 1, 4 and 6,
MPS
ma'am.
1,
4 and 6.
1,
Then 4 and
4 and
6,
6.
ma'am.
Even for Hunter, they have found out no. So
Okay.
1, 2, 4, and 6.
Then
MPS, you have told, Gaucher, you have told, very good. Then
Fabry's disease,
Fabry
and Pompe, ma'am.
and Pompe. Very good.
Pompe.
So these are the conditions for which enzyme replacement therapy is right now available. So you have to find whether in this list, are you considering any disease in this list for your child?
No, ma'am. Only Gaucher's.
No. So your exaggerated startle and all is there. So no.
No,
So what would be your management in this particular child? It comes as say, let us say it is the GM1 gangliosidosis. So management.
we have to give supportive management for developmental delay, ma'am. We have to give early stimulation and therapy. And for seizures, we have to give anti-epileptic.
Whatever may be the symptoms or the complications of the manifestation the child is going to, we are going to give a supportive therapy. So right now the child is having a generalized hypotonia only. So child can have physiotherapy or occupational therapy. Yes. Next. Child is having seizures, no.
We have to give anti-epileptic medications, ma'am. After doing an EEG, and then
Not necessarily. So you consider History is very important, and the video recording is important. When you happen to see a video recording, if you are satisfied that it is a seizure, you have to start the anti-seizure medications. Very good. Next.
Okay. Then we have to give adequate nutritional support and
Mother is asking whether this
speech
can be
therapy.
cured.
And also we have to give
Mother is
speech
asking whether it
therapy.
can. Okay. All therapies you are
We
giving.
have to give
PT,
we have
OT,
to
PT,
antenatal
OT,
counseling.
ST. Very good. Whether you can. There is something is that cure. You have to say no.
There is no
Present
cure.
moment there is. And so, and the very important thing is the genetic counseling. What kind of disorders are these things?
Autosomal recessive, ma'am.
Can you mention, can you name extreme recessive disorders among this group? Among this degenerative conditions or LSDs?
Adrenoleukodystrophy, it is an X-linked disorder. Then Palisades Mass-Baker disease.
Number 2.
It is an X-linked. Then Rett syndrome.
Rett syndrome is X-linked dominant. It is not. It is a dominant one. Very good. Then among the MPS, all are autosomal
the
recessive.
second one, Hunter, ma'am. Hunter, ma'am.
Very
Hunter's
good.
disease.
Hunter. Then ones. Meningitis. Which is X-linked recessive disorder. Yeah. So these things they may ask you, so you have to be ready with the answers. What about the hearing loss in this particular child? How are you going to explain? Whether it is whether could it be a sensory neural hearing loss or could it be or conductive hearing loss? What type of hearing loss you can have in MPS?
It is conductive hearing loss in MPS, ma'am.
Conductive hearing loss, very important. Sensory neural hearing loss means you have to consider mitochondrial mother disorders. Okay. So you have to check the hearing also. So in the evaluation, you have to add a hearing evaluation as well. Okay. So that would, and the most important thing is we are not going to do much for this child. Hence, genetic counseling is much more important. Suppose this is a GM1 gangliosidosis, and it comes as it is a WES also says confirms diagnosis. How will you counsel the mother? The mode of inheritance, you know pretty well that it is an autosomal recessive disorder. So now you have to counsel the mother. How will you do that?
Since it is an autosomal recessive condition, there is 25% of risk for the next baby to be affected. So we have to do a prenatal testing.
Each child. It is not like out of 4, one will be having all the 3, 2 will be carrier and 1 will be now totally normal. Each child carries a risk of 25% of recurrence of this disorder. Hence,
we have to do a prenatal testing.
When?
At 18 to 20 weeks with amniocentesis or
till 20 weeks you will wait so that when she does the amniocentesis, how long will it take for a genetic report to come to us?
1 month, almost
weeks,
3 weeks.
4 to 6. 4 to 6 weeks is it is taking. So once if you are taking an amniocentesis by 20 weeks and the report comes after 24 weeks. Okay, so as early as possible, you have to do one. Once you have to counsel the mother in such a manner, she knows she is pregnant, she has to come for amniocentesis, either chorionic villus biopsy or amniocentesis, and do the same genetic test. So there lies the importance. So the enzyme assay alone is not sufficient. You have to confirm the diagnosis by genetic mutation study so that for the next pregnancy, you can do the amniocentesis and confirm whether the particular fetus is affected by the same mutation or not. Then advise the mother accordingly, either to terminate the pregnancy or to continue the pregnancy depending upon the genetic. Okay. Okay, ma'am. Very good. Anything else you want to ask? Hello. With that, we complete the case discussion, sir.
Hello, Kirtana, you can stop sharing the screen. Okay. Any questions to anyone?
That was an excellent discussion, madam. And Kirtana answered very well. Kirtana, in the provisional diagnosis in the list, the fourth one you mentioned as syndromes. The better you could have considered epileptic syndromes, because initial there was no perinatal insult, neonatal period was normal, and developmental stagnation with seizures started after some time. So instead of the syndrome, epileptic syndrome is what you meant. That is one. And in the general examination part, when you're getting a large head, lot of ocular features are important. Madam highlighted. The sun-setting sign is important. The gaze is important because we are considering the Niemann-Pick, Gauche, many other things. So sideways or vertical gaze is important. Corneal opacity you didn't mention that time, madam only. So lot of things are there in the eye in this case. Fundus you mentioned, and cherry spot may not be appearing early in many of these cases. So ocular findings. Another, there is a dysmorphic appearance, gross appearance is the other findings. The liver, you said it is 4 centimeters, but the span was only 4. That looks a little odd, because in a case like this with the gross facies also, possibility of a gray matter with the hepatosplenomegaly situation with the seizures. So that is how we narrow down the possibilities. In the demonstration part, your glabellar tap, your demonstration, always the finger should be coming from the back part. It should not be in the visual field. The menace reflex will be interfering with that. When you're representing the power and the reflex again, power is more than 3 grade. So rather than that, you're considering 3 maybe in a younger child, anything more than 3 is normal. So you better tell it is a normal or not, rather than more than 3 can be anything. So it should not be vague like that. And in the reflex representation, whenever you are representing the reflex bilateral, it should be both sides should be represented there in the reflex. It should not be one only. Then in the examination, cardiovascular system is important, because in a situation like this, any of these things, MBS, acidosis, all the DDs, it can involve the heart also. Cardiac murmur or apex is important. In the examination, apart from the power, reflex and all, joint movement, because many of these things involve the ligaments and the movement may not be complete. So that is important. The head circumference, we consider the possibility of neuronal spheroid lipofuscinosis also, but the head circumference used to be a little on the lower side in the NCL. So when there is a large head, a little odd for the NCL. Definitely an interactable seizure situation happening of that. One of the DDs is the head circumference, but it used to be a little on the lower side. All the other discussion was an excellent discussion. Thank you, madam, for first time we are getting an expert from Tamil Nadu. We used to follow you. Thank you. An excellent discussion,
Thank
madam.
you, sir. Thank you, sir. Thank you very much for the additional input, sir. Thank you very much, sir.
Can we close the session?
There are no more people. Well discussed, covered everything about the storage part, and including the last part, genetic part, and counseling, and availability of a few of the conditions with the stem cell transplantation, few of them still not enzyme replacement is going down. That's അതല്ലേ ഇപ്പൊ major enzyme displacement is very
Yes.
expensive അല്ലേ?
Very expensive.
So maybe stem cell transplantation will come in a big way in all these conditions later, genetic. We can wind up,
So,
Dase.
thank you, madam, for accepting our invitation and sparing your valuable time with us. And
Thank you, sir. Thank you for the nice opportunity, sir. Really, I'm really happy to discuss all these things for the students.
Really, thank you, madam. And thank you, Kirtana, for presenting the case well. And
Yeah, it was a nice presentation. She did it very well.
Did very well.
Congratulations, Dr. Kirtana. Yeah.
okay.
Okay,
Thank you all. Good night. Good night, madam.
Thank you.
Sir, good night.